this will be a very short lecture. So you can ask anything if you want, if you are not sure about it. And then we can revise what we have spoken last time. So emergencies in congenital heart disease, mainly we will be talking about adults. So there are few presentations we need to concentrate that I will be addressing during the next 45 minutes. So the first one, these adult congenital heart disease, as we spoke last time, whether they are operated or unoperated, palliated patients, they can come with chest pain, they can come with arrhythmias, they can come with a wound infection if they have undergone surgical intervention recently, or they can come with the exacerbation of cyanosis, or they can come with heart failure and some infections like infective endocarditis. So I will be very briefly touching on this, how to tackle these patients if you are working in an emergency department, and then what to do after that. Most of the time, you will be making a diagnosis, tentative diagnosis, and then you call for a help within your hospital, most likely from an adult cardiologist, and then you will be transferring to a center where the adult congenital, or we have no adult congenital heart disease, but we have a only pediatric center. So those patients should come over there. So if you uh, see the presentation, I will take the presentation when they are coming with tachycardia or chest pain. Most likely, adults should be able to tell you that I have palpitation. So the first simple investigation is to do 12-lead ECG, where you will see whether this patient is having tachycardia or bradycardia. Both can present with hypotension or chest pain or collapse or whatever. So ECG is going to be the first important investigation. And then if you take the arm on the left side, if the patient is having tachycardia and symptomatic, the first assessment, you would have studied this one before, whether the patient is hemodynamically stable or whether the patient is hemodynamically unstable. This is your ALS courses. You would have seen this algorithm, how to manage this. I don't have to talk too much about it. So this is a standard adult guideline. We see whether the broad or narrow complex tachycardia and the patient is hemodynamically unstable, you go for cardioversion. And the next term would be a hemodynamically stable patient. So then you again analyze the ECG, whether it's a broad complex tachycardia or narrow complex tachycardia. There are various overlap sometime with the bundle branch block. Sometimes you see a broad complex tachycardia with some changes. So these are beyond the scope of this lecture, but the general classification is, again, you see broad complex tachycardia, and then usually nowadays they don't use the term of narrow complex tachycardia. They say broad complex or normal complex, QRS complex tachycardia. So whether it's a sustained or non-sustained, if it is a non-sustained one, that you go for rate control. If it is a sustained, you need to do ideally, if you have the availability and access for transesophageal echocardiogram, you need to make sure there are no clots, and then atrial appendage and other areas, because these people are more prone for clots if the functions are abnormal, and then you cardiovert them. If normal complex tachycardia, then you look for P waves. If it is not visible, if the P waves are not seen, then you do vagal maneuvers, but doesn't work most of the time. Then you give intravenous adenosine. Then you will make the diagnosis whether it's a flutter or SVT, or whether it's a AVNRT, AVRT, whatever you make the diagnosis, and then manage accordingly the drug specific for that atrial tachycardia or arrhythmia. And if the P waves are visible, then you control with a rate control. There are various options. You can give beta blockers, you can give calcium channel blockers. These are standard adult cardiology practice. Then later, the second step, then you manage them, make them stable, and then you consider there's IV infusions of amiodarone, those kind of medications, oral amiodarone, those you can start, and then you can refer them for electrophysiological study and to consider ablation. That is one way you can do when the patient is stable, and then refer to the tertiary care center. So that is about symptomatic tachycardia. So in summary, see whether the patient is stable or unstable, and then you decide on which way you are going to take. And symptomatic bradycardia, especially very low heart rate, and they can present with syncope, collapse, dizziness. So then sometimes these people would have been on beta blockers or the heart rate controlling agents. So that should be withdrawn with caution, with your advice from the adult cardiologist. And then you can, if symptomatic, very low, then you go for a temporary pacemaker, and then you go for permanent pacemaker once the patient is stable. So bradycardia is easy. Tachycardia would be the most difficult thing to manage. Some patients will have resistant tachycardia. So you have to be very careful. Airway, breathing, circulation, that has to be done. So if you take the summary of, this slide would have been given to you. If you take various heart disease, I have given here. If you take here, and arrhythmias, most common emergency, that is the main thing more than chest pain. And the atrial tachycardia is most common, more common in adult congenital heart disease practice, considering the surgeries they undergo and fontan circulation and various other things. And if you take the tetralogy fellow, will be the other high risk category. They can present with VT or sudden cardiac death, and they say increases after the second decade of life, and the sudden death increases by 2% per decade in tetralogy fellow. So tetralogy fellow patients you will encounter more and more hereafter in your day-to-day practice. And if they are coming with cardiac arrest or extremely poor circulation, first thing to consider is VT. So you need to do the ECG, take the appropriate steps to manage them. This is the summary. You don't have to remember everything. Just you can read whenever you are there, since you have been provided with the slides. So whether there can be supraventricular arrhythmias, ventricular arrhythmias, bradycardias, and I have listed here the this is from ESC guideline. So the second ACHD, what kind of arrhythmias are more common down the line? If you see TGA, which is more common, which kind of arrhythmias are more common? If you see arterial switch, VT can occur, SVT can occur. And if you say CCTGA, we saw the images last time, it's a congenitally corrected TGA. They are at high risk of heart block also. So every congenitally corrected TGA, if you see a diagnosed patient coming to the clinic, ECG is a must, because they might develop complete heart block later in life, even though it was not seen before. So those are the summary of various heart disease versus various type of tachycardia or bradycardia. Okay. Next slide. Slides. Okay. Okay. So, arrhythmia evaluation and treatment, as I have mentioned, they can present with dizziness, palpitation, syncope, dyspnea, chest pain, and it can be cardiac arrest. So, investigation-wise, ECG is a must. And then once the patient is stable or while in the hospital, you can put them on a halter. For example, if the child is coming, or the patient is coming with a ventricular ectopics or ventricular tachycardia, you need to assess the if it is non-sustained ventricular tachycardia, you need to assess the ventricular burden, ventricular ectopic burdens. And sometimes we wait for 20% burden. Sometimes you have a low threshold of even 10 to 15% of ventricular ectopic burden, you start treatment. And in a tertiary center, you can refer them for EP studies, for ablations, whether it's coming from right ventricle, left ventricle, whether it's from the free wall. So there are various studies you can do and find out where the ventricular ectopics are coming or ventricular atrial ectopics are coming, and then you can ablate them. And echocardiogram is very important one to assess the function. Sometimes if you don't have the facility of getting a halter immediately, but if the function is down, if the function is not normal, then you might probably think that ventricular ectopic burden is very high, which is causing the ventricular, the decreased ventricular function. So echocardiogram is later, you can do one echocardiogram to assess the LV dilatation or chamber dilatation. So management, as I have mentioned, so you start on antiarrhythmic medications, catheter ablation. If it is a bradycardia, you can go for pacemaker implantation and surgical intervention. Sometimes these atrial arrhythmias during the surgery, you can tell the surgeons to do the MACE procedure just to prevent atrial arrhythmias. Sometimes they do it prophylactically, considering some high-risk patients. Um, Specific managements of some main arrhythmias. If it is an atrial fibrillation, you control the rate and cardioversion. And in adults, main thing is anticoagulation, because they are very high risk patients to get stroke if we have not converted. When we are converting, what will happen is during atrial fibrillations or arrhythmia, the ventricular function will be poor. And when we control the rate, the contractility will be better, and it will start ejecting all the clots which have been forming around the heart area, especially this atrial appendage and other risk places. So that will throw emboli into the brain and other parts. So you have to anticoagulate them when you are converting them. And if you think this is a sinus SA node dysfunction, and then you ask for a EP opinion or an adult cardiology opinion where they do a lot of pacemaker, and then you can go for a pacemaker. And VT, if the child or the patient, adult congenital patient, have got some VTs, maybe because of, I'm talking about congenital heart disease, but there are other syndromes with high burden of or the risk of VT, for example, Brugada and long QT syndrome, those kind of patients. If you think the patient had a significant arrest and resuscitated once, and probably they put medications, but in ICDs, intracardiac defibrillator, will be the choice if we have the facilities to buy that one. But nowadays in Sri Lanka, these devices are very less in number. So in other countries, they will go for ICD straight away. So that will shock the patient as soon as he goes into BT, and you can uh, mention in the ICD when you are setting up the ICD, you can say after this amount of ventricular beats, you shock the patient, and this is the threshold, you can set everything. So that is one way of managing that. And these people are more prone people, are one of like mainly the tetralogy of Fallot, as I have mentioned before, and sometimes this transposition of great artery patients whom we have done the surgery, like arterial switch operation. And so that is all about arrhythmia. And when they come with shortness of breath, again, there are so many causes of shortness of breath in adults with congenital heart disease. It can be left heart failure. So if you take left heart failure, sometimes your ejection fraction is very low. Sometimes there is a left heart failure with preserved ejection fraction. And sometimes those are all systolic, what we are talking about systolic function. Or sometimes they can have diastolic dysfunction, especially restrictive cardiomyopathy or restrictive heart disease for some other reasons. And that is about left heart failure, or they can come with right heart failure, depending on which heart is affected. And because of previous surgeries and high risk, they can present with even arrhythmia for a long time. The cardiac function will deteriorate, and then they can present with features of heart failure. And sometimes, as I have mentioned last time, AV canal defect patients, when we repair, we won't be able to repair the valves to 100%. So they can present with valve regurgitations. Therefore, like a mitral regurgitation or tricuspid regurgitation, they present with heart failure. Sometimes they can go into heart failure, right heart failure, because of severe or large pulmonary embolism or thrombosis. So all these should be considered when the patient is admitted with shortness of breath. And you sometimes our patients won't bring all the diagnosis card, or sometimes they won't bring all the interventions what has been done before. So you have to think about all differential diagnosis when you are managing. And at an emergency department now, I think people are more trained on the sats and saturations, and ECG is compulsory, which is available in most of the centers with A&E. But the focus, that is point of care ultrasound, is available most of the time. I think all at least one person or in the ship should be trained to do this if you are at a tertiary or like a general hospital. So what are we going to see? These maybe these probes, focus the ultrasounds may not have a proper cardiac probe, but you can just keep a probe of ultrasound probe to see whether the left ventricular function, whether it is poor or not. Most of the time we get referrals, this child or the patient has poor LV contraction. Sometimes you see a dilated LA, left atrium. So if you see a dilated left atrium, you know then the left ventricular hypertrophy, or it is called the diastolic dysfunction. It's a basic thing to identify. Are we struggling with a diastolic dysfunction or a systolic dysfunction? Sometimes you see a significant right ventricular hypertrophy, thick right ventricle, and poor RV function. Then you have to think about pulmonary hypertension or pulmonary embolism. So this is only three main things to look at. You look at the LV, look at the RV, and look at the LA. Then a tentative diagnosis can be made. Then you can manage according to that. And management wise, so airway breathing circulation is very important in any case. And then if the features of heart failure are there, and then you give them diuretics, good IV diuretics should be good to bring the pulmonary edema down. And you can, if the blood pressures are stable, you can start vasodilators to reduce the afterload. And then Then if once the patient is stable, sometimes these people might need intubation to manage the left heart failure. Then you transport to a tertiary care center with congenital heart disease facilities, and then we can manage over there. So that is about heart failure, shortness of breath. Causes can be various causes, but the assessment is same and the management is going to be most of the time the basic management is same unless there are any contraindications. So this is the summary. So patient is coming with a heart failure. You take the history, physical examination, and the past medical records, and then you decide whether this patient is in cardiogenic shock, and then you manage the emergency at that point. Or the patient is just having edema, ascites, and dyspnea without evidence of shock, and then you manage as a routine care. So if he is in shock and you have to ventilate, you have to do all the emergencies as indicated. So what are the things we are going to see? First thing, as normal standard things, we check, we connect the ECGs, we put the blood pressure cuff and check the blood pressure. And if the blood pressure is maybe very high, sometimes high blood pressures can cause hypertension and heart failure, or the blood pressure may be very low because of the poor LV function. And then ECG, you look for, as I have mentioned, look for arrhythmias. And I don't know whether these tests are available here. BNP to see the severity of heart failure. Sometimes there are figures. If it is this figure, the heart failure is significant, especially cardiomyopathy, heart failure. You do that and see. And then routine investigations. If these are adult patients, they can have other medical problems, diabetes, infections, complete blood count, blood biochemistry. So all these things have to be done, and you do the hemoglobin to check whether there is anemia, whether there is uncontrolled infection, diabetes, how the renal failure, because what will happen is if the heart is failing, then you have to look for endocrine failures, whether the renal hit, whether there is a renal hit, whether there is a liver hit. Those everything will tell you to what extent we are going to manage this patient, whether we have to control the fluids, whether we have to give bolus of IV fluids. Everything will depend on how individual patients are differing from each and every patient is different. So you have to find out exactly what is happening to that patient, and you have to manage. And echocardiogram is very important after settling and managing the emergencies. So as I have mentioned, we have to see ventricular function, dysfunction, whether it's systolic function or diastolic dysfunction. And the other thing is some of these post-op patients can present with pericardial effusion. So that we have to be very careful, because unless you intervene this pericardial effusion, you drain it, you won't succeed in your management, because that is the management of choice, is to drain the pericardial effusion. And there are indirect signs of pulmonary embolism. If you are lucky, you will see the big thrombus in the pulmonary artery. Sometimes there are indirect signs, whether the artery will dilate and the pressures will go up. So the cardiologist will tell you there are indirect signs of pulmonary embolism, and then they will go ask for a urgent CT to diagnose, and then you have to do the specific therapy. So X-ray is very important. Once the patient is stable, you do an in-ward X-ray. And at the same time, you had to do a thoracic ultrasound. And the echo also, you can see this effusion. Sometimes these fontan completion patients, some of the chronic heart failure patients whom we have operated, severe valve regurgitation, heart is failing. So most of the time, they will be presenting with significant pleural effusion. So then unless you drain the pleural effusion, the cardiac function and the cardiac output will not improve. So these are the specific guideline you have to think. So in broad sense, so you see whether the child or the patient is sick, in shock, and you manage the emergency ventilation and fluids and those kind of management. And then you look for, if the child patient is stable, then you do the routine care of systematic analysis of each and every organ and every system you have to take care of. And the one of the other thing what you do if you have the facility is the blood gas will tell you how we are ventilating, how the lactate is, how the mixed venous saturation is. Those are the things will tell you which way the patient is progressing. You can assess the progress by doing a blood gas. If the patient is improving, your lactate will come down, your renal component will improve. So that is one way of monitoring your management. And chest pain, I won't touch too much on this because this would have been dealt with by adult cardiologists. So even you should not forget that congenital heart disease patients also can present with acute coronary syndrome, and some people are even at a higher risk for the reasons given below. If you see on your left, so the defect itself will carry a high risk. For example, a TGA patient, or we have done coronary translocations. I have mentioned last time, the patients can have right coronary artery arising from the left coronary sinus, the left coronary artery arising from the right coronary sinus. These are abnormal coronaries, so they can get compressed by the compressed between aorta and pulmonary artery, and sometimes the surgical repairs will damage the coronaries, coronary stenosis. And if you see these adult congenital patients, many of them are obese later in their life because they can't do good exercise. The other thing is they have a sedentary life. Most of them are depressed, so they don't engage in sports activities. Because of that, they are at high risk, and some of them are hypertensive, so they have again at high risk for acute coronary syndromes. And one thing you should not forget, a patient who has been operated and having a right to left shunt, they can have the paradoxical embolism, which can go from the right side to the left side, can go into the coronary, and can have acute coronary syndrome. We have seen enough of sometimes the adult congenital patients, undiagnosed ASDs, they come first time with acute coronary syndrome. You do a coronary angiogram, there or usually a CT coronary angiogram, and you will see completely normal coronaries. But if you see the ECGs on presentation, they will have ST elevations and features of acute coronary syndromes. Then the diagnosis will be made that this is a right to left shunt at the ASD level or whatever the lesions. We had enough patients. So then the management is to close the defect if possible. So you had to, I have mentioned to you last time, if there is a right to left shunt, if there is a ASD, how to assess when the child or the patient is suitable for closure. If the patient is suitable, I think you have to close the defect rather than tackling the coronary, because there is nothing to tackle in the coronaries because this is due to right to left shunt. And pulmonary embolism is very important. Emergency, you have to diagnose early as possible. There are ECG changes, there are echocardiogram changes, and the clinical features. And then what are the common causes? Maybe dilated cardiomyopathy, they may be having an arrhythmia, and they can have because of chronic hypoxia, because of polycythemia and arrhythmia. Those are the common causes of in adult congenital heart category patients. They can come with this pulmonary embolism. And next one, I think I have briefly touched upon aortic dissection last time with aortopathy. Patient, for example, Marfan syndrome and other connective tissue disorders. And the other people who are more prone to get aortic dissection, one is tetralogy fellow. If you can remember tetralogy fellow, before operation, the aorta is overriding. So it is taking blood from right ventricle and left ventricle. So the flow through the aorta is comparatively higher than the pulmonary artery. So more the blood is going through the aorta, then they have a chance of getting dilated. And they have some intrinsic disease also for dilated aorta. So they can have aortic dissection and TGA, parctation. These are the congenital heart disease people. They can have aortic dissection because they are more prone to get this aortic disease. And the risk factors are other risk factors. If they have hypertension, hyperlipidemia, and diabetes, you had to think about dissection. You would have heard about dissection, how they present sudden onset of unbearable chest pain, usually interscapular at the back. Then you should not uh, uh, miss them. You had to immediately investigate appropriately and you had to diagnose. And the other major thing I will be discussing is the pulmonary hypertension. So these people also will be presenting with chest pain. Sometimes first time presentation, primary pulmonary hypertension, or sometimes with these shunt lesions undiagnosed in childhood, presenting first time with severe pulmonary hypertension, which is very common. So if they, so this is a quite big chart, but all we have discussed here. So they present with chest pain, you assess them, history, physical examination, ECG, and if it is a post-surgical problem, you dealt with the surgical issues. If it is a wound or something, infection, you tackle them. And if the patient is stable, you analyze differential diagnosis, what are the causes I have mentioned here. If the patient is stable and ECG shows STEMI, and if there is STEMI, then you send to the cath lab. If there is no STEMI, and you rule out all the problems mentioned here, including orthopedic, vascular, pulmonary, those kind of things. And if the patient is not stable, and then you had to think about very bad conditions or dangerous conditions you had to rule out. Those are whether there is a pulmonary embolism, acute aortic dissection, or there is a tension pneumothorax. Some connective tissue disorder patients, especially Marfan's, they can present with spontaneous rupture of and then pneumothorax. So don't think that you should have a pneumothorax in case of accident, but they can have it without anything. And the pericardial tamponade, especially patients who have undergone surgery recently, and esophageal perforation. These are all possible. They all can come with severe chest pain, and they are unstable. So this is a big graph, a chart, but easy to follow. So if there is STEMI, you follow them. If there is no STEMI, and if there is a pericardial effusion, this is where the focus is important. Uh, uh, so you do the ultrasound, just see whether there is a big effusion. You call the cardiologist or your intensivist, and they will immediately tackle that. You do an X-ray, if there is a pneumothorax, immediately ICU chest drain should go in. So if you are not sure, the next way is go for a CT scan if you have if you have facilities to do the CT scan. I won't mention the other medical problems here, which is beyond the scope. And this one I will mention, this is the main topic here. So most of the cyanotic heart disease patients, either if they have been operated already or if they have not undergone operation and undetected or palliated, they can come with exacerbated cyanosis. So main thing is you should have all the records and you should contact the ACHD center, adult congenital center, or a pediatric congenital or pediatric cardiologist to see what should be done first and whether what are the intervention possible. Whether nothing can be done, you have to manage medically, and conservative management should be discussed with the patients. And the other problem is they can come with hyperviscosity syndromes, and sometimes they can have hemoglobin, very high hemoglobins of 17, 18, PCV of 70, 80. The current guideline for polycythemia and hyperviscosity, usually the first line is you admit them, hydrate them over 48 24 to 48 hours. And usually venesection is not recommended for the latest guideline. So those days we used to admit them, take the blood, replace with the saline. But there is an indication for hyperviscosity. If the PCV is very high, there is a stroke, and you suspect this is hyperviscosity and polycythemia induced stroke, then yes, you can do the venesection, and at the same time you have to replace with the fluid. But most of the time, if the patient is otherwise stable, no end organ damage, most of the time you have to hydrate them rather than taking the blood out. And always cyanotic patients, because they are polycythemic, we should not think that they are not anemic, the iron levels. So most of the time they are having low iron levels. So these people should be treated with folic acid and iron, because they are iron deficient, because they are producing more and more hemoglobin and the iron stores are less. So you have to treat them. And you have to think about fontan circulation. I will discuss that one in the later slides. So you had to do X-rays, you had to consider echo, and you had to consider cardiac catheterization and cerebral CT to make sure that we are not missing any infarction due to hyperviscosity. So management I have mentioned here. So any cyanotic exacerbation, give enough oxygen. Don't restrict oxygen here. Sometimes the fear is in not in your category, in pediatric category. Sometimes they think giving oxygen will shut down the PDA or whatever. So it doesn't happen. So if the patient comes with cyanosis, give enough oxygen, hydrate them very nicely with boluses, and give iron supplementations. And specific therapy I will discuss in the next slides, at the end of the slide. So next presentation could be infective endocarditis. There is nothing to discuss, but you should know what are the indications where you have to give infective endocarditis prophylaxis. Nowadays, WHO has recommended following these important things as infective endocarditis prophylaxis. But certain countries like UK and European Union, some of the countries, they remove this and they don't recommend routine prophylaxis of infective endocarditis. But in our setup, we follow WHO guideline. So any patient with prosthetic valve, it can be a transcatheter valves, or it's an open heart surgery with a ring. We have to give infective endocarditis. If the patient has had infective endocarditis before, you have to give it prophylaxis, and you have to think about infective endocarditis when they present with fever, and you should not jump and start antibiotics unless the patient is dying. So always take three cultures from the three different sites, probably within 24 hours. But you can ask the microbiologist what is the best option. So that is one thing. And any cyanotic congenital heart disease, they are at risk of infective endocarditis. Cyanotic, not acyanotic, cyanotic heart disease. And a patient who has been repaired with a prosthetic material, for example, we close VSDs with a patch or a ASD with a patch. So if you do that for 6 months from the time of procedure, there is a risk of infective endocarditis, and the patient should be given infective endocarditis prophylaxis. And lifelong infective endocarditis prophylaxis if there is a residual shunt or valvular regurgitation. These are all applicable here in our setup, but not for in other countries where they have changed the guideline. So what are we going to do? Clinical suspicion of infective endocarditis. So these are the categories I have mentioned: prosthetic valves, prosthetic rings, previous endocarditis, congenital heart disease, repaired within last 6 months. They are considered at high risk. So you do the blood counts, CRP, calcitonin if you have the facilities, blood cultures. And the last two, if you have facilities, for example, a mitral valve has been replaced or repaired, you do a transesophageal echocardiography and see vegetations. And PET scan is nowadays, that is a trend. If you can't, sometimes you see a vegetations, that vegetation can be there for ages, 6 months calcified. You will still see a vegetation, but you don't know whether that vegetation is active or not. Then in that case, the best investigation would be a PET scan to see the active focus. The radiologist will tell you whether the focus is still active and inflamed. So if these are negative, you should have a low suspicion, and then you observe them, but you should have a low suspicion all the time. After cultures, you can take antibiotics, you can give antibiotics, and then depending on the culture, you can manage. But if it is positive, contact your microbiologist in your center, and then they will tell you what exact management options are. Most of the time, minimum duration of antibiotics is 6 weeks if you have a vegetation and proven endocarditis. That is very important. If you don't treat them, it'll keep on growing, and then it'll become a surgical emergency. It can damage the valve, then the patient will go into valve surgery. So these are the important thing in endocarditis. Pulmonary hypertension. This is probably the last one I will be talking on. So there are two types of pulmonary hypertension. If you see this image, this is the capillary, the alveoli at the center. The capillaries are either side of the alveoli. So the blood coming from RA, RV, pulmonary arteries go to the pulmonary artery and divide and arterioles and end up in capillaries. And then the capillary will come back here and join to form the pulmonary venules, and then it becomes pulmonary venous pulmonary veins, and then it reaches the left atrium and left ventricle and aorta. So whether pulmonary hypertension, there are two types, basically three types, but the main important things are two types. Whether the pulmonary hypertension is pre-capillary or it is post-capillary. So post-capillary means pulmonary hypertension is caused because of problems in the left side. For example, severe mitral stenosis, increased LA pressure, increased pulmonary venous pressure, and this will cause back pressure in the pulmonary arteries, and then that causes pulmonary hypertension. So in that case, if you go and measure the blood pressure, the pressure in the pulmonary capillary wedge pressure, that is mentioned as PCWP. If you measure the pressure somewhere here, indirect measurements, what you do is you go to the pulmonary artery, go to the end towards the capillary and you take the pressure, that will tell you the pressures on this side. So pulmonary capillary blood pressure, if it is more than 15 millimeter mercury, you diagnose as post-capillary. If it is less than 15, that is pre-capillary. So you can have both pre and post mixed capillary. You don't have to remember this one, but this is the latest guideline. Earlier, the pulmonary hypertension guideline, the mean pulmonary artery blood pressure, that is the main thing to go ahead. So if the mean pulmonary artery blood pressure is more than 20, you diagnose as pulmonary hypertension. Earlier it was 25. Now WHO and ESC guidelines, they have changed to 20. And as I have mentioned, pre-capillary and post-capillary. So pre-capillary, both, if you see the mean pressures are more than 20, we don't know. So by looking at the PA pressure, we don't know whether it's pre or post, but you can work out depending on the lesions. But the wedge pressures, if the wedge pressures are less than 15, then it is pre-capillary, more than 15 post-capillary. And pulmonary vascular resistance, more than 3 Woods unit, it is pre-capillary, and less than 3 because you are measuring in the pulmonary artery. If it is less than 3, that is post-capillary. I have given the reasons for various reasons for pulmonary hypertension. You don't have to remember everything, but the one common thing is the pulmonary vein obstruction. What we have here, if the vein is obstructed, it will create back pressure here. So the PA pressure from this end will go up. Mitral stenosis is the commonest one you see, and sometimes severe aortic stenosis. For example, the aortic valve is highly stenosed, so the left ventricular pressure will go up, and the left atrial pressure will go up, and the left pulmonary vein pressure, the pulmonary venous pressure will go up. Therefore, it will be reflected on the other side. So that is post-capillary blood pressure. So what do you do for these patients? The incidence in adult congenital heart disease patient is nearly 5 to 10%. And they can present with syncope, hemoptysis, heart failure, palpitation, chest pain, because the right heart is failing. So what is the main problem? Because of the pulmonary hypertension, they can't push blood into the pulmonary artery. If you have seen echoes of these patients, it will be a very sluggish flow into the pulmonary artery. That is what they don't do well in the exercise. They can't push more blood into the pulmonary arteries when they are doing exercise. So signs of inability to increase the pulmonary blood flow and cardiac output adequately, that will tell you the child or the patient is having pulmonary hypertension. So this is what, if you can remember in the previous lecture, assessment of ASD and VSDs, whether these are operable or not operable, inoperable, we have said we will put them on treadmill and to see how they are faring with the exercise. If they are not doing well, probably that will tell you they have elevated PA pressures. And what are the precipitants? They can have arrhythmias, dehydration, medication-induced pulmonary hypertension, excessive effort, that is exercise. Pregnancy, you have to be very careful. It can precipitate or exacerbate the pulmonary hypertension. That is what we advise them not to go for pregnancy. And infection also can aggravate pulmonary hypertension, especially the lung infection. So they can present with hemoptysis. So this is an emergency. Like, if you have a diagnosis card and pulmonary hypertension is mentioned there, now they are coming with hemoptysis. What are you going to do in the A&E? So you do the airway breathing and circulation. If you know that one lung has a high chance of bleeding from the operative record or previous history, they would have identified ruptured bleeding vessels from one side, you put them on the opposite side. If the right lung is involved, so what you have to turn lying on the side of the bleeding lung. So for example, because you should protect the opposite lung. So if the right lung is bleeding, so put them on right side so that the bleeding will not cause and bleed will not go into the left lung and occlude the normal lung. So if the patient has a diseased right lung, bleeding from right lung, put them on right side rather than the opposite side. And sometimes they do the deep endotracheal intubation to occlude that lung, to selectively intubate the normal lung to have a good gas exchange and protect the unaffected lung. And if you have facilities, we'll take them to the cath lab. And sometimes there are major vessels supplying, for example, a patient with a poor lung artery supply or pulmonary atresia, as I have mentioned, they will have a lot of direct communication from the aorta to the lung, because the lung from the beginning, the lung will think, I don't have enough blood supply from the pulmonary artery, so I'm going to get it directly from the aorta. So they get most of the blood from the aorta directly, and there is a high risk they can bleed and rupture. So if you find something, you can selectively go and occlude those vessels. And pulmonary hypertension can cause severe heart failure or cardiogenic shock, which is called as pulmonary hypertensive crisis, which is a very, very important emergency. So you need to maintain the blood pressure. Right side pressures are going up, so you have to improve the contractility of the left-sided blood pressure to counteract the right side, increase right side pressure. So you have to start them on inotropes. Pulmonary vasodilators. Nowadays, we have nitric oxide. You have to ventilate them, put them on nitric oxide, which is a vasodilator, pulmonary vasodilator, which is expensive, but it is life-saving. And intravenous prostacyclin, which we don't have, but in other countries, they will start prostacyclin and then keep them on prostacyclin. After COVID, they have prostacyclin nebulization also, which has been tried and proven effective. So you can do that. And careful adjustment of central venous pressure to optimize cardiac output. So you should not drop it too much. You should not allow it to overshoot also. So very carefully you will manage them. And if the blood pressures are low, you treat them with no adrenaline, is a vasoconstrictor, and you maintain the myocardial perfusion. So that is, you will study those under, I think, the inotropic medications. And important thing is if the patient is on any pulmonary hypertensive therapy, for example, in Sri Lanka, what we have is bosentan and sildenafil. So if the patient is on these medications, you should never stop them, because that will aggravate the pulmonary hypertensive crisis. So the last slide, the fontan circulation, because we have enough patients with fontan hanging around. So this is just a reminder, what is the fontan circulation? So pulmonary artery is there. The IVC is connected here. The SVC is connected there. So both are draining directly into the pulmonary artery. So they will put a hole there in the pulmonary, in the conduit. This is a pop-up valve, as I have told you, because if for the circulation to happen, how the circulation is happening, the lower part of the body, IVC blood comes to the pulmonary artery, upper part of the body, SVC comes to the pulmonary artery, go to the lung, go to the alveoli, oxygenated, come back pulmonary through the pulmonary vein, come to the ventricle, single ventricle, and go to the aorta. So the saturated blood coming from the pulmonary vein is going directly into the aorta. The unsaturated blood is coming into the pulmonary artery directly rather than going through the ventricle and mixing with the other saturated blood. So surgeons, they leave a hole here. Why they leave a hole is because if the pulmonary artery pressure goes up for any reason, because these two flows are happening passively, no, there is no active contraction of the cardiac muscle here. So for the passive flow of SVC and IVC, you need to have a certain low blood pressure in the lungs, preferably around 15 millimeter mercury. For some reasons, as they grow, they can have high pressure. So what will happen? If there are no communication here, the blood can't go in. The IVC can't go, SVC can't come here. Then there won't be any pulmonary venous return, because to get the pulmonary venous return, the blood should reach the pulmonary artery. If it doesn't reach, then you won't get the cardiac output. To prevent that, they put a valve here. For example, the PA pressures have gone up 20. So the IVC can't eject blood into the pulmonary artery. So that will directly eject the blood into the ventricle. So the cardiac output will be maintained. The patient will be alive, but patient will be desaturating, because now the desaturated blood is going there. So cyanosis in front-end circulation is an emergency. If they come with cyanosis, there are so many reasons. Usually their saturations are around 90 to 95, but the saturations, if it is less than 90, it can be due to high PA pressure and the fenestration shunting from this conduit to the atrium, and pulmonary AV malformations. That is one common thing. So they bypass the alveolar circuit. So pulmonary artery blood will come directly into the LA or directly reach the pulmonary vein, which is a pulmonary AV malformation, arteriovenous malformations. Sometimes they form collaterals. So you manage them. Here, main diagnostic modality is cardiac catheter. And if we see something, we will call them and occlude them. This is one of the font circulation. This is the angiogram, as I have mentioned to you. The catheter has come through the leg, has come through the IVC, and come through the font circulation here, and then injecting into the SVC area. So if you can see, the patient is intubated, SVC flow is flowing into the lungs, and the IVC flow is flowing into the lung. And you can see you can see a jet of blood here, which is the fenestration, which is shunting. This is a life-saving. The patient will desaturate, but this is important for life-saving. And similarly, here is another patient. Here again, you see the fenestration here. So again, a pressure angiogram is given. You can see the lung arborizations. So these are given to see whether the patient has got pulmonary AV malformations, collaterals, those kind of data. So the final slide is the surgical wound problem. This is straightforward, because after surgery, they can come with the wound infection. Physical examination, opening and examining the wound is very important. So you have to see redness or dehiscence, sometimes gaping of the wound. You have to inform the surgeon, take swabs from there, and immediately after taking the cultures and things, immediately you had to start on antibiotics, and you had to inform the surgeon. And if most of the time they do a wound dressing, and they start on antibiotics. Okay, so that's the emergency bit. I have touched most of the emergencies, but not in great detail because of the time constraints. But you can ask if you want any clarification.
Thank you, Raghu. First, we will allow them to do the 2 MCQs.